Thanks. And I'm going to hide my slide for once it's up. I'm going to hide it there because I don't need it yet. So this has been an incredibly good day and an amazing amount to think about. And Jim has done a phenomenal job of sort of summarizing this in a conceptual way. I'm going to do what we should never do, which is some navel gazing, inward navel gazing within public health. We love doing it, and it tends to slow us down a lot. But I'd like to talk a little bit about it, the implications of all we've heard today for public health, and in a sense, think about public health readiness for this kind of world, because I think Jim's point about these mechanisms moving forward very rapidly, the question is, can we catch up and keep up with them in order to take advantage of them? Because those who are making social investment probably are neutral about whether it's housing, community development, public health. There are just many different ways you can invest your dollar socially, and we need to be ready to compete in this environment. And I'm not sure that we are, and see what some of those challenges are. So, part of, I guess, since early this morning, the question is this a lot of change that we are seeing, or is this a lot of chaos, or is it a little bit of both? And certainly from, the discussions with those within health, meaning public health and health care, it definitely is a little bit of both. And that's an opportunity to try to impose some order on this chaos, because I think everyone is feeling incredibly insecure about the level and pace of change that is happening. And no one really has a North Star of, we know how this is going to turn out in the end. So everyone is sort of making it up as we're going along. The imperatives, this again gets to Jim's point about things are happening really fast. The imperative for the health system to change is much more immediate because the financing systems are changing so dramatically. Public health could probably limp along as it is now because funding is relatively even, and another 2% cut, another 5%. Well, we did it last year, we can do it again next year, and we'll just keep doing what we're doing. That's a model for ultimate failure, but I think there's a greater danger of inertia on the public health side than there probably is on the healthcare side, because the system isn't allowing the healthcare side to stand still. I think, so that's one area of sort of change and chaos. I think the second, that is a challenge that we constantly address in this roundtable and in many other forums, is giving a health purpose to similar or related investments, which is a little bit different than health and all policies. But I think we saw that from the community reinvestment panel, that sometimes stumbling on the health impact by accident and sort of saying, wow, that's really cool, maybe we'll do more of that. And how do we give it a greater purpose so that people actually go into this investment process in the community with health in mind? And the third part of this change or chaos concept is, again, going back to the conversation about population health, and actually the common theme, if you really look below that argument around population health, we're really talking about place-based interventions. And if you talk about place, that can be the community, that can be a state, it can be the nation, but if you're thinking about place rather than population, that breaks down some barriers as well, I think. It doesn't totally eliminate the concepts of population health as everyone uses it, but I was really struck by Gary's comment about, the hospital can make the biggest impact on health by preventing people from crossing the street to the hospital building itself, and thinking about different sides of the street. So very different concept of how we, or a really useful way of framing how we do things. So what does this mean for public health? There's still going to be things that public health continues to need to do. There are going to be investments of the kind we heard about today that will mean that public health no longer needs to do some of the things that it does. And there are going to be other instances where some of the things that public health has been doing will now continue in parallel with what these new investments are doing, because Lord knows we have not gotten all the money we need. Even if we can't say how much it is, we know we don't have enough. So this does mean that we're going to be working with new partners, and that requires all sorts of new language. Certainly, we heard that over and over again today. And it means, but it does provide an opportunity and a platform, if we are willing to play that role, to be what a number of us have been talking about for some time, that public health is sort of the chief health strategist for a community. Not necessarily in collecting data, because actually health systems may have a whole lot more data than we, public health, will ever be able to collect, but in analyzing and using that data in a different way that frames the issues differently. We heard about the value of health impact assessments and how that can make a difference. So there are all sorts of things that public health can do that informs this discussion, whether it's a bunch of investors who are trying to figure out what is the most effective way of doing business, or the most important place, or where I'm going to get the largest return on investment. It also means being comfortable with some level of accountability without necessarily having line responsibility. And that's always a little scary. I'm going to be held accountable by my mayor, my governor, my county executive for the health of the community, but I'm depending on all these other people to really improve the health of the community, and I don't have any direct authority over them. That's scary, but it goes back to being the chief health strategist and being able to exercise soft power rather than direct power. And a lot of public health is built on exercising direct power. We see a problem, we intervene, we fix it, and it's done. This is very, very different. It also, though, means that in this softer leadership role, that we can be tapping resources that will never be part of our aligned budget. And so while I will obviously agree that we will never have enough money, or we're not even close to having enough money, we're probably never going to be able to get that perfect accounting for how much is invested in population health, because as we convince more and more people, or more and more investments or programs to give health purpose to what they are doing that chart of accounts is going to be more and more complicated. We would probably never have thought to count as a public health investment removing the carpet in that daycare center. And yet it was. And maybe we shouldn't even try to do that level of accounting. There's going to be a critical federal, we talked a lot about community, but there's going to be a critical federal role in motivating these partnerships, in making it easier for all of us to work across sectors. And we didn't talk much about that today, but I was pleased to see at the confirmation hearing for the president's nominee for Surgeon General, Vivek Murthy, both Senator Harkin, that would have been expected, but Senator Mikulski, who will be staying on as chair of the Appropriations Committee, really grilling him about what are you going to do with the National Prevention Council and how are you going to make that more effective, which I think is incredibly important, because that is the place where the 20 or so federal agencies and offices come together and can be talking about not just removing barriers, but perhaps providing incentives for these different programs to be working together. So you see we spend a lot of money and energy creating these structures in the community to braid together different funding streams so that they will work and sustain our projects. We do that within health, we do that out. We obviously, it was clear from the presentations, do it in community development as well. And now we want to mix health and community development and also and education, all these together. The federal government can do a lot to make that job easier. And right now it's putting up a lot of barriers, and it would be wonderful to see the Prevention Council taking the lead in creating some of those initiatives. We've seen, so, and the last couple of panels, but particularly the last panel around pay for success, I think raises some fundamental issues for how we think about our work. There are lots of legal and practical issues. You know, the wrong pocket issue is a huge one in terms of, you know, how you actually repay your investor and how you really capture those savings. Those are hard, but they are soluble ultimately. But we in public health have never worked on a pay for success basis. So going back to 1994, 1995, when the federal government actually tried to create, I think they were called performance partnership grants, that actually did tie a tiny bit of your money to, tiny bit of money to success in exchange for a lot more flexibility. That was killed by the public health community. People didn't want that. Everyone wanted to hold on to their individual line item to do what they thought was the best thing with no accountability for success. So we talk in great, you know, in these contexts, we're very excited about this notion of, oh, there's some money out there. But that money is tied with being able to change our way of doing business and to accept the fact that we will be held accountable for our success and not just trying hard and doing God's work. That you know, we've considered necessary and sufficient to deserve that funding stream. These models don't permit that anymore, and that's also something the healthcare system is learning as the financial incentives change. I don't know what that means for how we structure public health, how we do public health. I just know that it means some really major changes in how we go about our business. So all of this does feel very big, and I'm almost done. But I just want to show this slide, and you know, I think Jim's conceptual model is a really good one, and so now I'm going to commit the sin of narrowing our profile back into our own little world of health after all of this discussion about community development, and that's only because this slide was created actually in 2007 or 2008, and some of the early conversations were created about, gee, how can we create, you know, something that looks like a wellness trust in a community to promote both clinical and community preventive services. So it was before we had the prevention fund, it was before we had community prevention grants or community transformation grants or CPPW or any of that other alphabet soup. But the basic concept was building on the notion that there is some sort of a return on investment for doing community prevention work. How can we get the various players to contribute? And did there need to be an entity that could integrate or be the backbone or the quarterback to, we never use those terms though, to bring these things together, if not to necessarily pool the money, though that could be one option, but at least to have everyone agree how that money would be allocated across the community so that it would be done in a reasonable and integrated way. What's encouraging is that there are a number of jurisdictions that are looking at that and creating this in different ways. The California State Innovation Model Grant is looking at creating wellness trusts that would look mostly at health dollars. That's a first step, and the start, I think, of being able to have this conversation and create the sustainable, I think what Debbie was getting at earlier, create a sustainable mechanism for supporting that quarterback or backbone organization or integrator so that they can then just worry about doing the business of getting, improving the population's health.